All right, good afternoon, students. So let's begin. Today we have lecture which is called Syndrome in Pulmonology, Syndromes in Pulmonology. Yes, I know that part of this information you passed already, but maybe I will refresh a little bit your knowledge. And I think it will be useful for you because next meeting you have conclusion and you will have to answer on each of these questions about which I will tell you today. So, about what syndromes we will talk. So, next syndromes. Syndrome of fluid in pleural cavity, fluid accumulation in pleural cavity, syndrome of air accumulation in pleural cavity, syndrome of thickening pleural membranes, syndrome of cavity in the lungs, syndrome of consolidation of pulmonary tissue, and syndrome of bronchial obstruction, syndrome of increased airness of the lungs, and last topic is dedicated to syndromes of compression and obstructive atelectasis and syndrome of respiratory insufficiency. So first is syndrome of fluid accumulation in pleural cavity. So what do we know about it already? First of all, normally you know that there is small amount of the fluid near 1 milliliter between pleural layers. But pleural effusion is when it is more than 1 milliliter, 10, 20 milliliter of fluid or even more. So fluid in the pleural cavity may be different. It may be a water, transudate or exudate. It may be blood, pus, and also lymph. What complaints may have these patients? The most common of them, of course, will be dyspnea, of course, may be present and dry cough, and may be present pleural chest pain. To treat pleural effusion appropriately, it is important to determine, of course, its etiology. That is why we take the samples of this fluid to examination. However, the etiology of pleural effusion remains unclear in nearly 20% of cases. So, thoracentesis should be performed for new and unexplained pleural effusions. Now, what is transudate and exudate? So, transudate is non-inflammatory fluid that occurs in disorders of lymph and blood circulation in the lungs, for example, due to the heart failure. So what causes of it? On the first place is heart failure, but also it may be due to liver cirrhosis and mitral stenosis, pericardial disease, different kidney abnormalities, which may begin from nephrotic syndrome, pulmonary embolism. Of course, treatment with help of the dialysis, it may be peritoneal dialysis or hemodialysis. And the treatment in this case, of course, should be treatment of the underlying disease. And exudate or effusion in the pleural cavity is formed due to inflammation or tumors. So the causes of this condition will be, of course, pneumonia, which is the most common, also tuberculosis, tumors, pulmonary embolism. It may be also in case of myocardial infarction or perforation of the esophagus, pancreas, also autoimmune disease such as systemic lupus erythematosus or rheumatoid arthritis may cause this problem. Reaction to the introduction of some drugs, for example, amiodarone or methotrexate, and cardiac surgery and chest irradiation. Now, the syndrome of accumulation of the fluid in pleural cavity is presented by two diseases, two main disorders, which are hydrothorax and pleurisy with effusion. So hydrothorax, it is a type of pleural effusion in which transudate accumulates in the pleural cavity, which is non-inflammatory effusion, for example, in cardiac failure, as was mentioned. And pleurisy with effusion occurs when it is some inflammation of the pleura. Pleural effusions also may develop following the accumulation of other fluids with the pleural cavity, for example, blood, or maybe pus, or maybe lymph, and will be called hemothorax, pneumothorax, and helothorax respectively. Now, as always, we start examination of the patient from the taking of complaints and history of the disease. So history of the disease provides information about the possible etiology of the pleural effusion, which is of course useful for us. For example, history of pneumonia may suggest parapneumonic effusion. It may be complicated or uncomplicated. Also, fever indicates infective etiology. History of cardiac, renal, or liver impairment can suggest transudative effusion. Older age, weight loss, and history of smoking point toward the diagnosis of malignant pleural effusion. And what is also important, trauma. Trauma may result in hemothorax or helothorax. Complaints. On the first place, as always, here is mentioned dyspnea. So dyspnea may be mostly expiratory or even mixed. Chest examinations show us asymmetry of the chest. On palpation will be markedly weakened vocal fremitus, of course, over the area of the pleural effusion, or maybe in some cases even undetermined if there is a big amount of fluid inside. Now, on percussion, we can hear or doubt or absolute dullness. On auscultation, bronchophony is markedly weakened or even absent. Now, examinations which we are using. Of course, instrumental examination, chest X-ray, ultrasound, and computer tomography. Laboratory examination, as was mentioned, we have to take the samples of this fluid for the examination of this fluid. So examination of pleural fluid. So what we can mention about ultrasound? So even small amounts of pleural effusion can be detected accurately by ultrasonography. So the ultrasonographic image of pleural effusion is characterized by an echo-free space between the visceral and parietal pleura. Ultrasonography is useful in cases of loculated pleural effusion for confirmation of the diagnosis and, of course, for making a site for thoracocentesis. Now, CT scan, CT of the thorax. So computer tomography scanning with its cross-sectional images can be used to evaluate complex situations in which the anatomy cannot be fully assessed by plain radiography or ultrasonography. CT scan can be useful in helping to select the site of drainage of an empyema, for example, differentiating empyema from lung abscess, and in identifying the location of the chest tube in failed empyema drainage. But what we have to understand that, of course, CT is always the user to see inside the body without cutting, but we should remember that radiation used in CT scan can damage body cells, including DNA molecules, which can lead to radiation-induced cancer. Now, let's watch short video about X-ray of the chest.
You can think of X-rays as photos made from high-energy photons that penetrate the body tissues so that we can see what's going on inside. Just like visible light, X-rays are less likely to penetrate denser materials. Conventional X-rays that show white bones on a black background are like photographic negatives. The darkest parts of the film, like the lungs, are areas where more photons can penetrate the body. In contrast, the sharp, bright white areas are where the dense bone material blocks photons from getting through. Let's go through this chest X-ray using an easy-to-remember checklist associated with the first 7 letters of the alphabet: A, B, C, D, E, F, G. A stands for assessment. To avoid errors and wasted time, you should always begin by assessing the patient and exam data. You want to verify the patient's data with the exam data, or the medical record number, date of the exam, etc., to ensure that you are looking at the right study and patient. You also need to assess image quality, because this will impact the accuracy of the test in detecting pathology. For example, to ensure there isn't excess rotation of the patient, you should make sure that the medial ends of the spinous processes are equally distant from the border of the vertebral bodies. Rotation throws off the usual X-ray anatomy and introduces unwanted variation. Next, a good inspiration film should show at least the 10th or 11th posterior ribs. If the lungs are not fully expanded, we might miss important diseases. Finally, we need to make sure that the exposure isn't too bright or too dark. To check for this, you can look for fine markings in the lung fields to make sure they're visible. If the fine lung markings aren't visible, then the X-ray may fail to detect some diseases. A also reminds us to make sure there isn't air where it shouldn't be. Finding air where it should not be, or more commonly, ruling it out, remains one of the most important uses of medical X-rays. Diagnoses like pneumothorax, pneumomediastinum, pneumoperitoneum, and subcutaneous emphysema are all examples of air where it shouldn't be. All of these are surgical emergencies and can be diagnosed by a simple chest X-ray. Finally, if the major airways, like the trachea, are bent or deviated, another example of air where it shouldn't be, it may signal an underlying mass. B is for bones. Start by looking at both clavicles and all 12 pairs of ribs one at a time to make sure that there are no fractures, deformities, or missing bones. B is also for the body wall and soft tissues outside of the chest. This is an easily overlooked part of the chest X-ray, and it should be checked for swelling, masses, and other things. C is for cardiac silhouette and size. This is the cardiac silhouette, and there's an atrial appendage, the right atrium, and the left ventricle. Remember, in chest X-rays, we define features relative to the patient, so the right atrium is on the left side of this X-ray, and the left ventricle is on the right side. Measuring across a normal heart is less than 50% of the greatest diameter of the rib cage measured from the inner portion of each rib. Any larger, and there may be cardiac pathology. D is for the diaphragms, which shouldn't be too flat, but appear fairly symmetric. You can assess flatness on the lateral view by estimating that the hemidiaphragm is 1.5 centimeters above the line connecting the costophrenic angle posteriorly and sternophrenic angle anteriorly. E is for equipment, such as lines, tubes, and wires involved in life support. It's important to note exactly where they're located relative to other structures and whether they're in functional position. For example, an endotracheal tube should be in the middle of the trachea, and its tip should be more than 2 centimeters from the tracheal bifurcation, or that a nasogastric tube should have its tip well within the stomach. E is also a reminder to check for a pleural effusion, which is a common but subtle form of pathology that you can see on an X-ray. Pleural effusions are fluid that collects at the costophrenic angle, and causes blunting of the normally sharp costophrenic angle. F is for lung fields, which should look symmetric. There shouldn't be any haziness, white dots, or blotches. While looking at lung fields, having a frontal and a lateral X-ray allows us to determine in which lobe of which lung an abnormality is located. In this case, a nodular mass is visible in the inferior, lateral, and anterior left lung, meaning it's most likely within the anteromedial basal subsegment of the lower left lobe. This can be confirmed with a chest CT. Lastly, G is for great vessels, which includes the superior vena cava, inferior vena cava, ascending aorta, aortic arch, pulmonary artery, and descending aorta. You want to make sure that all of these structures are in the right location and is the right size. On the left side of the heart, the aortic arch should be the highest up, followed by the pulmonary artery. Of note, since the heart is three-dimensional, the atrial appendage actually sits behind the central formation in frontal X-ray. On the right side, the superior vena cava, ascending aorta, right ventricle, left ventricle, and inferior vena cava should all be visible. Deviation may be the result of congenital abnormality or disease. Okay, to recap, using A, B, C, D, E, F, G. A is for the assessment of data and quality, as well as looking for air where it should not be. B is for bones in the body wall. C is for cardiac silhouette and size. D is for diaphragms. E is for equipment and effusions. F is for lung fields. And G is for great vessels.
Tak. All right. Now, before I will continue, students, please, everyone who are in Zoom, put a plus in the chat. Thank you. Now, We was learning ACG, X-ray, sorry, previous semester, yes? So you partly, I hope, remember all that mentioned in video information, because if you will not know norms, you of course will not understand abnormalities. So first, I want to show you a first example of abnormality with pleural effusion on the chest X-ray. So standard posterior, anterior, and lateral chest radiography remains the most important technique for initial diagnosis of pleural effusion. We have here posterior anterior film and lateral film, which is which show us information in more details. So the amount of fluid to be evident on a posterior anterior film is 200 milliliters, whereas costophrenic angle blunting can be appreciated on a lateral film when approximately 50 milliliters of fluid has accumulated. So less fluid is visible on the lateral film. Now, how do we distinguish hydrothorax from pleural effusion with help of chest X-ray? So X-ray examination reveals an area of increased density in the area of accumulation of the pleural fluid, which is usually at the bottom of the chest, often bilateral if it is hydrothorax. If transsudate is accumulated in the pleural cavity, its border is more horizontal. But if it is exudate while in the presence of pleural effusion, the border is scant to coincide with the Damoyes curve as determined by percussion. Now, one more example for you. This is pleural effusion. So right pleural effusion due to lupus erythematosus in 12-year-old child. Note compressed middle and lower lobes of the right lung. Here it is on the picture A. The effusion was evacuated and the right lung was completely re-expanded after insertion of the pigtail chest tube. So here it is, picture B. Now, pleurocentesis or thoracocentesis. So it is a puncture of the chest wall for excretion of pleural fluid in order to determine its properties for accurate diagnosis. So thoracocentesis should be performed in all patients with more than a minimal pleural effusion. And what is the use of pleurocentesis? It is not only used to take samples for the pleural fluid, yes, for diagnostic studies, but also it is used to remove this fluid from the pleural cavity, yes. So as a method of treatment, it is widely used. Now, what do we have to know about norms of pleural fluid? So normally, pleural fluid has the following characteristics, such as clear infiltrate of blood plasma with a pH of 7.6 to 7.64, protein content less than 2%, near 10 to 20 grams per liter, less than 1,000 leukocytes, sugar content similar to blood plasma, and LDH levels less than 50% of plasma levels. Sodium, potassium, and calcium levels are similar to intracellular fluid. So in clinical practice, exudate can be clearly differentiated from transsudate based on light criteria. So the effusion should be considered an exudate in the presence of at least one of the following features. The ratio of levels of protein in the pleural fluid to a similar value in the serum is more than 0.5. Or the ratio of the level of LDH of the pleural fluid to the value in the serum is more than 0.6. Or the level of LDH in pleural fluid is more than 2/3 of the upper limit of normal for serum LDH. Now, what complications may happen due to thoracocentesis? It may cause pneumothorax, it may cause bleeding, it may cause infections, and in some cases, liver or spleen injury. Prophylaxis of it, of course, using valve tubes to ensure that no air enters during suction of fluid, using antiseptics and sterilized tools, and localize this place of puncture precisely, and if possible, of course, to use ultrasound detection. Now, next syndrome is syndrome of air accumulation in pleural cavity. And one disease is presenting this syndrome, which is called pneumothorax. So pneumothorax is the presence of air in the pleural cavity which enters there due to damage of the lungs of the chest wall. So the air in the pleural cavity compresses the lungs, which causes deterioration of gas exchange. Air is accumulated in the pleural cavity when the bronchi are communicated with pleural cavity. For example, is in subpleural tuberculosis cover or abscess, in injury to the chest, or in artificial pneumothorax. There are three main groups of classifications of pneumothorax. Depending on the reason, we distinguish spontaneous, post-traumatic, and iatrogenic pneumothorax. Depending on mechanism of occurrence, we distinguish closed, open, and tense or valve, or also called tension pneumothorax. And tension pneumothorax, it is a life-threatening variant of pneumothorax, which is characterized by progressively increasing pressure within the chest and cardiorespiratory compromise. And finally, given the size of the width of the pneumothorax cavity, we distinguish two types, small and large. Small when it is less than 2 centimeters, large when it is more or equal to centimeters. So, what may be revealed during inquiring of the patient and physical examination? Complaints of the patient may be pleural pain in the chest and shortness of breath or dyspnea. On the chest examination may be revealed asymmetry of the chest, and the affected side of the chest cannot take part in the respiratory act. On palpation, vocal fremitus is markedly weaker or absent. On percussion, of course, that specific sound will be revealed, which is called tympanic sound. And on auscultation, breathing sounds and bronchophony are either weak or absent. Now, instrumental and laboratory methods which we are using. In this case, of course, will be the same instrumental methods and chest X-ray and computer tomography and ultrasound like in previous syndrome. But in the laboratory method here, more useful is ABG test, yes, arterial blood gases test. So we have to check the arterial blood gases because due to pneumothorax will be reduction of oxygen saturation, may be revealed hypoxemia, hypercapnia, and respiratory acidosis. Okay, so first example of syndrome of air accumulation in pleural cavity. Here we have tension pneumothorax. So tension pneumothorax on the left and is displacing the heart and mediastinal structures to the right, as we can see here. So this case also show a deep sulcus sign on the left, which is matched with help of yellow arrow. There is an underlying hyaline membrane disease. Now, next example is large pneumothorax. So spontaneous pneumothorax in patient with Marfan syndrome. It is necessary to pay attention to the complete absence of pulmonary pattern on the left side. Here it is, or on the left hemithorax. So the apparent volumetric formation in the area of the root, here it is, of the lung is actually a collapsed left lung. Now, next example is complete right-sided pneumothorax. Radiograph of the patient with a complete right-sided pneumothorax due to a stab wound. Next syndrome is called syndrome of thickening pleural membranes. And again, only one disease is presenting this syndrome, which is called dry pleurisy. So it is a pathology of the respiratory system that characterized by bands and commissures formation between pleural layers and increase of their thickness due to the inflammation. So what can we reveal during physical examination of the patient and inquiring of the patient? First of all, complaints. Here we have pain in the chest, specific to this problem. Cough mostly is dry, but here also your patient may have high temperature. And lying on the affected side lessens the pain. On the chest examination will be revealed unilateral thoracic lagging during respiration, On percussion, decreased mobility of the lung borders on the affected side. And finally, specific sound may be revealed during auscultation of the lungs, which is called pleural friction sound or pleural friction roof over the inflamed side. Dry pleurisy can be accompanied by pleural effusion, atelectasis, or empyema, so it may complicate the diagnosing of the problem. Now, about instrumental and laboratory methods which we are using in this case. CT scan, ultrasound, and if it is necessary, pleurocentesis or thoracocentesis. We are also using X-ray, but X-ray will not give us understanding that it is dry pleurisy. It will not show us signs of dry pleurisy on the X-ray. But as a method of exclusion, we are using it. Next syndrome is syndrome of cavity in the lungs. And three things need to be remembered. First of all, pulmonary cavities are thick-walled abnormal gas-filled spaces within the lung. They are usually associated with a nodule, mass, or area of consolidation. A fluid level within the space also may be present. So X-ray and CT form the mainstay of imaging. So cavity in the lungs is formed in abscess or tuberculosis or during degradation of the lung tumor. Besides that, cavities frequently arise within a mass or an area of consolidation as a result of necrosis. Cysts usually contain air, but occasionally contain fluid or solid materials. What may be revealed during physical examination? Nothing specific, no specific complaints may be. But on chest examination may be unilateral thoracic lagging. On palpation, intensified vocal fremitus. On percussion, it depends from what is in this cavity. So maybe dulled tympani or tympani with a metallic tinkling. On auscultation, amphoric breathing, which is also intensified bronchophony. And in some cases, maybe heart rails. Now, first example. Here we have lung abscess. So there is a thick-walled cavity, white arrow here, with a smooth inner margin, here it is, red arrow, located in the right lung. So an air fluid level is present. Here it is measured with help of black arrow. Next example, case of pulmonary tuberculosis. How do we know that it is tuberculosis? Of course, we know some information from the history of the illness. Patients have dry cough, low-grade fever, and loss of the weight since 2 months. A well-defined thick-walled cavitary lesion is noted in the right parahilar area in the mid-zone of the right lung, and here it is. Next syndrome, syndrome of consolidation of the pulmonary tissue. And in some cases, the alveoli can fill up with substance, for example, with pus, protein, blood, and water, cancer cells, etc. So this substance is called lung infiltrate. The alveoli filled with infiltrate can be seen on the chest X-ray as an area denser than the surrounding lung tissue called consolidation. So syndrome of consolidation of pulmonary tissue is one of the most widespread syndrome of the respiratory system pathology. So the syndrome of consolidation of the lung tissue is caused by filling of the alveoli with the inflammatory fluid and fibrin, for example, due to pneumonia, blood in case of lung infarction, growing connective tissue in the lung, for example, in case of pneumosclerosis or carniциfication, and in long-standing pneumonia or developing tumors. Complaints of the patient may be next: shortness of breath, cough, and chest pain. On physical examination may be revealed next things. Examination of the chest shows lack of the affected site in the act of breathing. Palpation over consolidated area may reveal vocal fremitus intensified, and percussion over consolidated area show us sound over the consolidated side slightly or absolutely down. And on auscultation, hard or bronchial breathing, moist wheezing, crepitation, and increased broncho. Now, radiography clarifies the diagnosis. Of course, it clarifies because it shows us the area of consolidation, its location, yes? But only with help of radiography, we cannot be sure what is the problem with the patient. That is why we also have to ask about the history of the illness. We have to ask about the complaints. We have to do other examinations and also physical examination of the patient. According to the X-ray, we distinguish lobar consolidation and diffuse consolidation. So lobar consolidation, it is a single pulmonary lobe consolidated without crossing any pleural lines. Consolidation affecting multiple pulmonary lobes is called diffuse consolidation. Causes of lobar consolidation may be lobar pneumonia, lung cancer or lymphoma, pulmonary hemorrhage or pulmonary infarction, cryptogenic organizing pneumonia, eosinophilic pneumonia, and sarcoidosis. Causes of diffuse consolidation or multifocal consolidation may be pulmonary edema, bronchopneumonia, fungal pneumonia, viral pneumonitis or tuberculosis, septic embolism, systemic diseases such as systemic lupus erythematosus, granulomatosis with polyangiitis, Goodpasture syndrome, Scheinlein-Henoch purpura, also primary lung cancer and metastasis, and also aspiration pneumonitis. Here we have first example of this syndrome, and we have here a posterior anterior film and lateral film. So right middle lobe consolidation in patient with lobar pneumonia. And also we confirm it with help of lateral film. Now, next example is diffuse consolidation. So diffuse consolidation in a patient with tuberculosis. So multiple consolidations in the both lungs. Now, one more example, lobar pneumonia. On the chest X-ray, there is an ill-defined area of increased density in the right upper lobe without volume loss. So the right hilus is in normal position, and notice the air bronchogram here. And this is an acute lobar pneumonia caused by Streptococcus pneumonia. As I said, with help just chest X-ray, we are not absolutely able to make proper diagnosis. That is why we always have to use other examinations. So other things need to be considered, like acute or chronic illness it is, clinical data, and other non-pulmonary findings. So here we have 6 examples of the chest X-rays with the signs of consolidation. First is lobar pneumonia. How we know that it is lobar pneumonia? First of all, of course, we know some information from the history of the illness. And mentioned information here is that patient is also having cough and fever for a long time. Now, second is example of pulmonary hemorrhage in the patient who is having hemoptysis or hemoptysis. Now, number 3 is organizing pneumonia, and this patient is having multiple chronic consolidations on the chest X-ray. Now, number 4, it is infarction and peripheral consolidations in the patients with acute shortness of breath is here. But besides that, we also revealed low oxygen level and in blood chemistry, high D-dimer. Number 5 is pulmonary cardiogenic edema, and this patient is having for a long time heart failure. So our task also is to distinguish, is it syndrome of consolidation of the pulmonary tissue, or maybe it is a syndrome of accumulation of the fluid in pleural cavity. Of course, we are using it if consolidation is in the lower parts of the lungs. So a pleural effusion is a collection of fluid in the space between the chest wall and lungs. Like lung consolidation, it looks like white areas against the darker air-filled lungs on the chest X-ray. Since an effusion is a fluid in relatively open space, It will usually move due to gravity when the patient changes his or her position. So a lung consolidation may also be fluid, but it is inside the lung, so it cannot move when the patient changes position. This is one way the doctor can tell the difference between the two. Now, some of the causes of pleural effusion, such as congestive heart failure, pneumonia, and lung cancer, also cause lung consolidation. So it is possible for the patient to have both at the same time. So examination plan consists of blood tests, sputum culture if necessary, CT scan, bronchoscopy if you suspect, for example, tumor, and of course, X-ray examination. Next syndrome is syndrome of bronchial obstruction. And approximately 100 heterogeneous diseases are associated with broncho-obstructive syndrome. Broncho-obstructive syndrome lays in basis of asthma, bronchoectasis, bronchitis, chronic obstructive pulmonary disease, and cystic fibrosis. So syndrome of bronchial obstruction is a set of symptoms related to reduced maximal expiratory flow during forced exhalation. So bronchial obstruction may be chronic and persistent in emphysema, for example, or episodic in bronchial asthma and recurrent in chronic bronchitis. What may be revealed on physical examination? Everything depends what disease causes this syndrome. But most common complaints will be expiratory dyspnea or attack of expiratory asthma if it is bronchial asthma. May be revealed barrel shape of the chest if this problem is due to emphysema. On palpation, increasing the resistance of the intercostal space and symmetrical weakening of tactile fremitus. So very specific sign of syndrome of bronchial obstruction is symmetrical injury, and you will find all the abnormalities in symmetrical areas. Now, on percussion, comparative percussion may reveal possible tympanic sound, and on topographic percussion may be revealed displacement of the lower lung limits from the bottom. On auscultation may be weakening of the vesicular breathing, again symmetrical, and in some cases may be revealed dry rales. So, diagnosis of obstructive disease requires several factors depending on the exact disease being diagnosed. However, one commonality between them is Pythnopainel index, or also called ratio between forced exhalation volume in 1 second over forced vital capacity, is less than 0.7 or less than 70%. Therefore, an important method of examination in this case will be spirometry. So not X-ray as in previous cases, but spirometry. The two main pathological conditions of pulmonary system are obstructive and restrictive pulmonary diseases. We can assess the above-mentioned conditions with next spirometric indicators such as forced exhalation volume in 1 second, forced vital capacity, and the ratio between forced exhalation volume in 1 second and forced vital capacity, which is once again called Pythnopainel index. So in measuring forced exhalation volume in 1 second over forced vital capacity via spirometry, the amount of air patient exhale is in 1 second is recorded, as well as the total amount of air patient is able to exhale. The ratio of these two values is expressed as a percentage. So this is the percentage of the forced vital capacity expired in 1 second. The test result is compared to the predicted value, which represents a normal result based on patient age, height, and sex. A normal ratio is 70% to 80% in adults and 85% in children. Now, what is the meaning of the changes? If the patient is having obstructive pulmonary disease, so as was mentioned, this ratio should be lower than 0.7. If it is restrictive pulmonary disease, so the ratio between forced exhalation volume in 1 second and forced vital capacity we expect will be increased, but in some cases it can be normal. So what diseases are associated with airflow obstruction? Of course, those which we mentioned already: asthma, chronic obstructive pulmonary disease, including chronic bronchitis due to the smoking, emphysema and bronchoectasis, and also bronchiolitis. And what restrictive defects may be revealed? Pulmonary fibrosis, deformities of the chest such as scoliosis, result of lung cancer surgery, infections and inflammatory diseases, neurological disorders, pleural effusion, and ascites. Now, next syndrome is syndrome of increased airness of the lungs. And again, only one disease is presenting this syndrome, which is called emphysema. So emphysema may be, and in case of syndrome of obstructive pulmonary disease, and syndrome of increased airness of the lungs. So the syndrome of increased airness of the pulmonary tissue is based on the protracted enlargement of residual air volume in the lung that clinically manifests by emphysema. And emphysema may be due to obstructive bronchitis, chronic pneumonia, long-standing bronchial asthma, occupational lung diseases. Also, lung emphysema occur in mechanical overdistension of the lungs and also in advanced age. Everything what will be revealed, of course, is due to emphysema. And what do we have here? Dyspnea, mostly expiratory. In long-standing disease, the chest becomes barrel-shaped or emphysematous. On percussion will be heard that specific sound for emphysema, which is called bandbox sound. On auscultation, diminished vesicular respiration will be revealed. So lung emphysema is characterized by increased airness of the lungs due to overdistended or destroyed alveoli. Chest X-ray is useful in diagnosing emphysema, but only when it is moderate or severe emphysema. At the beginning of this problem, no signs of it will be visible on the chest X-ray. So the X-ray picture of the lungs is especially transient. The lung borders are lowered. The mobility of the diaphragm is markedly limited. So increasing lung transparency, lowering the lower edges, and limiting diaphragm mobility will be seen on the chest X-ray. Now, next syndrome is syndrome of atelectasis. This is already your topic number 3. And what should we know? Atelectasis is a collapsed or airless state of the lung, which may be acute or chronic, and may involve all or only part of the lung. Like we can see here, example for A is only part of the lung, example B is the whole lung. Now, obstructive atelectasis, segmental or lobar, we can see here on the first chest X-ray picture. So displacement of fissures and homogeneous opacification of the collapsed lung. Now, compressive atelectasis or pulmonary collapse syndrome is on the picture B. So compressive atelectasis is at the left side, lung compression from outside by the fluid exudate. According to pathogenetic mechanism, atelectasis may be, as was mentioned, obstructive or compressive. Here we have the picture. Picture A shows us collapse of the lung in pneumothorax. Picture B, compression of the lung by pleural fluid. And picture C, resorption of the air from alveoli distal to an obstructed bronchus. Atelectasis may be an acute or chronic condition. Acute atelectasis, in acute atelectasis, the lung has recently collapsed and is primarily notable only for airlessness. In chronic atelectasis, the affected area is often characterized by a complex mixture of airlessness, infection, widening of the bronchi or bronchoectasis, destruction, and scarring or fibrosis. So, common complaints for both of the types of the collapse. So rapid occlusion with massive collapse, Rapid occlusion with massive collapse, particularly with infection. What may be, sorry. So what may be revealed during physical examination of the patient and inquiring of the patient? First of all, complaints. Pain on the affected side, sudden onset of dyspnea and cyanosis, a drop of blood pressure, tachycardia, elevated temperature, and even sometimes signs of the shock. Chest examination will reveal chest wall excursion in the area reduced or even absent. On percussion, may be heard dullness or flatness. Slowly developing atelectasis may be sometimes absolutely asymptomatic or cause minor pulmonary symptoms. Now, so first we have to talk about obstructive atelectasis. So in obstructive atelectasis, the chief cause of acute or chronic atelectasis is intraluminal bronchial obstruction, often due to plaques or tenacious bronchial exudates, endobronchial tumors, granulomas, or foramen bodies. Other causes include bronchial strictures or distortion. The main cause of obstructive pulmonary atelectasis may be bronchogenic cancer and foreign objects in bronchus. So the main complaints, symptoms, and signs of obstructive atelectasis may be breathlessness of mixed genesis and cough. On the chest examination, often without any features, but maybe limitation of respiratory movements. On palpation, there is no tactile fremitus. On percussion, dull sound in the lesion area. On auscultation, breath not auscultated, bronchophony not determined. Next up is compression atelectasis. So maybe due to external bronchial compression by enlarged lymph nodes, a tumor, or an aneurysm. External pulmonary compression by pleural fluid or gas due to pleural effusion on pneumothorax, and surfactant deficiency. What symptoms and signs of it? Shortness of breath, cough, and sometimes pain in the area of injury. Chest examination often without features. On palpation, increased tactile fremitus. On percussion, blunt tympanic or dull sound over the area of lesion. On auscultation, again, weakened vesicular or even absent breathing, and sometimes may be present crepitation. Clinically significant atelectasis is generally visible on the chest X-ray. Findings can include lung opacification and or loss of lung volume. Direct signs of atelectasis include displacement of interlobular fissures and mobile structures within the thorax, overinflation of the unaffected ipsilateral lobe or contralateral lung, and opacification of the collapsed lung. In addition to clinical significant findings on chest X-ray, patient may present with indirect signs and symptoms such as elevation of the diaphragm, shifting of the trachea, heart and mediastinum, displacement of the hilus, and shifting granulomas. Chest CT or bronchoscopy may be necessary if the cause of atelectasis is not clinically apparent. Now, first example of the chest X-ray. So, radiography discovers shadow of the collapsed part of the lung towards the root, may discover shadows of the lung tumor or fluid in pleural cavity or air in pleural cavity due to pneumothorax. Chest CT can help clarify the mechanism of collapse, and experienced interpreter can distinguish among the causes of atelectasis: endobronchial obstruction, compression due to intrapleural fluid or air, and scars resulting from chronic inflammation. Now, lobar atelectasis. Lobar atelectasis or lobar collapse is an important finding on the chest X-ray and has a limited differential diagnosis. The most common cause of atelectasis are bronchial carcinoma in smokers, mucus plaque in patients on mechanical ventilation or asthmatics, malpositioned endotracheal tube, and foramen body in children. Sometimes lobar atelectasis produces only mild volume loss due to overinflation of the lung parts. So right upper lobe atelectasis. Here is example. Findings, what do we have? Triangular density, elevated right hilus, triangular density on the picture A, posterior anterior picture. Also elevated right hilus and obliteration of the retrosternal clear space, which is seen on the lateral field, matched with help of red arrow. Next example is right upper lobe atelectasis. A common finding in atelectasis of the right upper lobe is standing of the diaphragm. So here it is, matched with help of blue arrow. This patient has a centrally located lung carcinoma with metastasis in both lungs. Here it is, matched with help of red arrows. Now, next example is right lower lobe atelectasis. This is chest X-ray of a 70-year-old male who fell from the stairs and has severe pain on the right flank. Notice the abnormal right border of the heart. Here it is. We don't see, it is abnormal right border of the heart on the picture A. The right interlobular artery is not visible because it is not surrounded by a aortic lung but by the collapsed lower lobe, which is adjacent to the right atrium. On the follow-up, picture B, chest film, the atelectasis has resolved. We assume that the atelectasis was a result of post-traumatic poor ventilation with mucus plugging. Notice the reappearance of the right interlobular artery, red arrow, here it is, and the normal right heart border, blue arrow. Next is total atelectasis. So the chest X-ray shows total atelectasis on the right lung due to mucus plugging. Chest X-ray A. Notice the displacement of the mediastinum to the right. Here it is. So the reaeration on the follow-up chest film after treatment with a suction catheter. Suction catheter is also visible on the chest X-ray. The mediastinum has regained its normal position. A common cause of total atelectasis of the lung is a ventilation tube that is positioned too deep and thus obstructing one of the main bronchi. Previous examples was obstructive atelectasis. Now we have example of compression atelectasis. So the chest X-ray show a nearly total opacification of the left hemithorax. This patient was known to have pleuratic carcinomatosis. The left lung is almost completely compressed by the pleural fluid. The compression of the lung by the loculated fluid collections is best seen on the on the CT image. Here it is, matched with help of the blue arrow. The CT scan was performed because the patient was suspected of having pulmonary emboli. And last syndrome for today is syndrome of respiratory insufficiency. So, respiratory insufficiency or failure is a condition with abnormal gas compression of the blood, or this abnormality is compensated for by intense work of the external respiratory apparatus and higher load on the heart. Many acute and chronic diseases of the bronchi and the lungs cause respiratory insufficiency. So respiratory insufficiency decreases functional abilities of the body. It should be noted that the external respiratory function is closely connected with the blood circulatory function. The hard work is intensified during external respiratory insufficiency, which is an important compensatory element of the heart function. The main mechanism of development of respiratory pulmonary insufficiency are next. Reduction of the processes of ventilation, perfusion, and diffusion of the gases at the level of alveolo-capillary membranes. Violation of alveolar ventilation, suppression of respiratory function, damage to the nerves that innervate the respiratory muscle, reduction of chest mobility, and reduction of lung elasticity. So syndrome of pulmonary insufficiency. Maintenance of normal gas exchange in the lung is possible, as it was already stated, only on condition of sharp interconnection of three components such as ventilation, gas diffusion through alveolar membrane, and capillary blood perfusion in the lungs. So respiratory failure is a clinical condition that happens when the respiratory system fails to maintain its main function, which is gas exchange, in which partial pressure of oxygen is lower than 60 millimeters mercury and partial pressure of carbon dioxide is higher than 50 millimeters mercury. So respiratory failure is classified according to blood gases abnormalities into type 1 and type 2. So type 1 is hypoxemic respiratory failure, has a partial pressure of oxygen less than 60 millimeter mercury, with normal or subnormal partial pressure of carbon dioxide. In this type, the gas exchange is impaired at the level of the alveolar capillary membrane. Examples of type 1 respiratory failure are carcinogenic or non-cardiogenic pulmonary edema and severe pneumonia. Type 2, which is called hypercapnic respiratory failure, has a partial pressure of carbon dioxide more than 50 millimeters mercury. Hypoxemia is common and it is due to respiratory pump failure. Which method of examination we are using in this case? On the first place is ABG test or arterial blood gases test. So arterial blood gas analysis is an essential part for diagnosing and managing the patient oxygenation status by partial pressure of oxygen and saturation of oxygen, ventilation status by partial pressure of carbon dioxide, and acid-base balance by pH and bicarbonate. So, as was mentioned, due to respiratory failure may be arterial hypoxemia. So arterial hypoxemia is when the partial pressure of oxygen is less than 80 millimeters mercury. At persons of young age, partial pressure of oxygen is about 95 millimeters mercury. To 40 years, it is reduced to 80 millimeters mercury. And 70 years, approximately 70 millimeters mercury. In the clinic, chronic respiratory diseases as the most frequent cause of arterial hypoxemia is the development of chronic respiratory insufficiency in chronic obstructive pulmonary disease. Also was mentioned conditions such as arterial hypocapnia and arterial hypercapnia. So arterial hypocapnia when partial pressure of oxygen is less than 35 millimeters mercury. Characteristic of the early stage respiratory insufficiency when arterial hypoxemia is compensated by the increased pulmonary ventilation, resulting in lower partial pressure of carbon dioxide and development of respiratory alkalosis. Arterial hypercapnia is when partial pressure of carbon dioxide is more than 45 millimeters mercury. A characteristic feature of the later stage respiratory insufficiency, when the removal of carbon dioxide through the alveolo-capillary membrane is disturbed. It is often noted respiratory acidosis is an important sign of severe respiratory insufficiency. Now, clinical signs of ventilation type of respiratory insufficiency. Here we distinguish three stages or 3 degrees. So, respiratory failure of the stage 1, at a broncho-obstructive or asthmatic syndrome, shortness of breath of expiratory character with participation of axillary muscle, moderate tachypnea, absence of cyanosis, so blood saturation at carrying out pulse oximetry over 90%. At growth of a foreign body of respiratory tract, moderate tachypnea of inspiratory character, absence of cyanosis, and partial pressure of carbon dioxide of 45 to 55 millimeters mercury may be observed. At respiratory failure of the second stage or degree, may be revealed. Shortness of breath of expiratory or inspiratory character may be mixed character in acute bronchiolitis with participation of axillary muscle. Respiration rate increases by 50 to 100% of the age norm. There is perioral cyanosis, tachycardia, blood saturation of about 90% but not lower, and partial pressure of carbon dioxide is between 56 and 70 millimeters mercury. And finally, respiratory failure stage 3. The marked or pronounced shortness of breath with participation of axillary muscle. Inspiratory or expiratory character. The marked or pronounced tachycardia, acrocyanosis, saturation of blood at carrying out pulse oximetry is less than 90%. So, classification of respiratory pulmonary insufficiency with examples of diagnosis. Here we distinguish obstructive, restrictive, and mixed type of respiratory insufficiency. According to this classification, obstructive type may be due to bronchial asthma, obstructive bronchitis, narrowing of the trachea, bronchi, laryngospasm, compression of the bronchi by the tumor. Restrictive type is due to pneumosclerosis, pneumothorax, hydrothorax, kyphoscoliosis, and even obesity. And finally, mixed type, mainly in pulmonary heart or cor pulmonale. Many manifestations of respiratory insufficiency may be. Among a large number of respiratory insufficiency signs, the following area are most significant in clinical practice. Dyspnea, cyanosis, it may be diffuse or central, enhanced work of respiratory muscle, intensification of circulation, tachycardia, minute volume increase, and change of respiratory volume and capacity. In practice, combined respiratory insufficiency is often met where pulmonary tissue elasticity disturbances as well as respiratory tract passage lesions are observed. So, concluding mentioned information about examination. What may be revealed during physical examination? First of all, complaints of the patient, shortness of breath. It may be expiratory, inspiratory, and mixed, tachypnea, and tachycardia. On examination of the chest may be revealed, depending on the problem, emphysematous shape of the chest, kyphoscoliotic shape of the chest, or other chronic pulmonary processes, pathological shapes of the chest. On palpation depends on the nature of the pulmonary process, most often weakened tactile primitus. On auscultation, weakened vesicular breathing, bronchophony is usually increased. And last is functional test results. So the most important method in diagnosing of pulmonary insufficiency is spirometry and ABG test. So may be revealed reduced tymphanopineal index, increased in minute breathing volume, hypoxemia, and venous hypercapnia. The following investigations are needed. As was mentioned, ABG test, chest radiography is needed as it can detect chest wall, pleural, and lung parenchymal lesions. Investigations needed for detecting the underlying cause of the respiratory failure may include an echocardiography and ACG and bronchoscopy and pulmonary function test and blood electrolytes and thyroid function test and sputum and blood and urine culture, and finally complete blood count also is useful. All right. Here is all this literature which maybe will be important for you and interesting to read about mentioned information. If you want, you can take a picture. Now, finally, students, please, again, put a plus in the chat who are present. And do you have any questions for me about mentioned information? All right, no questions?
No question, ma'am.
All right, very good. No questions. So I hope that if you don't have questions, so everything was clear for you. So students, again, I'm waiting for the pluses in the chat. Please do that for me. If you put it your plus, thank you for your attention, students. Have a pleasant weekend ahead and see some of you in classrooms or in Zooms next week. Bye-bye.
Thank you, doctor. Goodbye.
Goodbye, Dima.